Good evening, everyone. We're still having a little technical difficulties, but we're going to plow ahead. We're in the third year, and believe it or not, we're still having new things to discuss. And we hope that you'll find this evening providing you with information that may help you answer questions and be able to counsel your patients. We will lead off with Dr. Vishnu Chundy, who's well known to all of us, and we'll start with some epidemiology about where we are with these virus and virus variants.
Well, thank you, Ed. Thank you all for taking time out of your spring-like day today. Nice and wet still, but April showers do bring May flowers. So let's start. The graph that you're looking at is from like March 2020 going all the way to April 5th, 2022, believe it or not. And these are all the different waves that we've had with COVID-19. And the important thing here to look at is, what happened here? Can you go back? Yeah. So the important thing to look at is you're seeing this massive spike, and this is the Omicron signature with a rapid increase and a rapid decrease. And this blue one is actually Hong Kong, and this is South Korea. And you can see we went through our spike in the United States over here, and then Germany is still going up. Next slide. And the startling thing that you look at here is deaths, the 7-day rolling average of deaths per million. And Hong Kong has far exceeded any other country in the world, including India. And the reasoning is going to be delineated over the next few months. But it looks like in Hong Kong, there were several factors. One is that zero COVID policy where everybody was shut down. The second thing was the vaccine itself. Hong Kong received the Sinovac vaccine from China, the CoronaVac from Sinovac company, which is an inactivated vaccine. And interestingly, they had a lot of vaccine hesitancy amongst the elderly folks. And so a large number of elderly people in mainland China as well as Hong Kong are not vaccinated. So you see the mortality just skyrocketing in Hong Kong, and that's not what you saw with Omicron in most of the other countries except France and South Korea also had some vaccine hesitancy there and waning immunity. So this is something that's really you have to look for. Next slide. And you can see in Hong Kong, 66% of over 80s were unvaccinated when Omicron took off. And the case fatality rate, the CFR rate, was 4.7%. Now you look at New Zealand, where only 2% were vaccinated, and it shows you the case fatality rate was 0.1%. So the vaccines really do work quite well in preventing death and hospitalization still. Next slide. And then you can see the share of people who've completed the initial vaccination protocol. And you can see in South Korea, the rates are very, very high. In Australia, it's high. Canada is high. China is actually way up here, but their vaccines are not quite as good as what we have in the United States. And so the fear in China and what's going on in China right now, where there's big shutdowns of parts of the country, is because the rural Chinese are not as well vaccinated as the younger urban Chinese. Next slide. And then what's the dominant strain? It's all Omicron variant, and it's not just the BA1 variant, it's the BA2 variant now, which is taken off. And Kate's going to talk about that in a little while. So it's all Omicron. And next slide. And this is the slide that's startling about China. This is from the New York Times, which, by the way, has some of the best data around for this. And you can see what they mean by fully vaccinated, 89%. What that means is 2 doses, and that's really not fully vaccinated. You need 3 doses. And their vaccine that they're using, the CoronaVac, they're using several vaccines, but the majority is CoronaVac, is not quite as good as the mRNA vaccines. In fact, they've ordered a bunch of mRNA vaccines. And so China is in full lockdown mode in all sorts of places. In Shanghai, Guangdong, all these areas are in a lot of trouble. And you can see that the rates are just doing the Omicron, what the classical Omicron, going straight up, things that we've seen in the rest of the world. Next slide. And you can see that the other thing that's driven this is from Eric. This is from Bedford, out of University of Washington in Seattle, from the Hutchinson Institute, shows that the significant immune escape drove most of these large epidemics. And the blue line is Delta, and you can see Delta just kind of went away, and Omicron has taken over. And Omicron, and Kate's going to go over the reasonings, has significant immune escape, and that's a real problem, because there's also waning immunity, and the immunity doesn't last a whole long period of time. Immunity for Omicron, despite even 4 doses of vaccines, probably around at most 8 weeks, 12 weeks, and then it wanes for infection, not for death. Death is still pretty good. The hospitalizations, the deaths are pretty good. Next slide. And you can see throughout the world where most of the high vaccination rates are found in China, Australia, India. There are all of Africa is suffering from lack of vaccine. And even though their mortality rates appear low, there's pretty good data that it's because they just don't count very well, and their ability to count deaths and all that is not good. So there's a real problem in Africa, and this may drive more mutations. Next slide. And where Omicron is, it's present everywhere. You can basically say Omicron has taken over the world now, and it's really the BA.2 variant, and then the BA.3. There's more variants coming out from this, but truly BA.2 has taken over. Omicron BA.2 has taken over. Next slide. This is the CoronaVac. This was published in Clinical Infectious Diseases, and this basically tells you all vaccines, and this is the Pfizer BNT 162b2 vaccine, and this shows you what the ancestral lineage is with the original Wuhan strain. We had excellent coverage with that. And then this, what you're looking at, is the Omicron variant. You have pretty good coverage, and then you can see what CoronaVac does. There's literally no coverage with the CoronaVac virus that's been given all over the world. So we have a real problem in countries that have received the older CoronaVac vaccine. Next slide. And this is the 2 countries that have the best literature for this is Qatar and actually Israel, which Israel keeps publishing about because they have a nice good database, and they're following all their residents. And this is from MedRx about Qatar and their experience with infection, vaccination, hybrid immunity against symptomatic BA.1 and BA.2. Next slide. So the conclusions are there's no discernible differences in the effects of prior infection, vaccination, and hybrid immunity against BA.1 and 2. Hybrid immunity resulting from prior infection and recent booster confers the strongest protection against either subvariant, and vaccination enhances protection of those with a prior infection. Next slide. We can skip this. It's just basically the study design was pretty good. Next slide. And here's the real important thing. So this is effectiveness against symptomatic BA.1 infection. Okay, so if you had a prior infection, it gave you about a 50% protection against symptomatic BA.1 infection. 2 doses of the vaccine, you didn't have a ton of really protection against BA.1. 2 doses in a prior infection gave you about 51% infection. You got 3 doses, you had about a 60% against infection, and about 3 doses of vaccine and prior infection gave you about a 74% against just getting infected. And BA.2, very similar, okay? But then you go to hospitalizations and death, and you really have very good protection with hybrid immunity with 3 doses and a prior infection. And what it does tell you is if you just had prior infection, okay, against BA.2, against hospitalization and death, and 2 doses, it is not very effective. It's in the mid-70s. And what you really want is 3 doses of vaccine. And 3 doses in immunocompetent is considered a complete series for mRNA vaccines. And immunocompromised really is 4 doses. And the 5th dose would be considered a booster. So up to date is really 3 doses of vaccine today. And in the United States, we only have about 33 to 40% people have taken their 3rd dose of vaccine. Next slide. So what does all this mean? Prior infection alone confers poor immunity against Omicron BA.2. 3 doses are required to prevent hospitalization and death. And hybrid immunity with vaccination and infection provides the best protection, and then immunity wanes. And with the New England Journal data yesterday, we know that the immunity wanes pretty much by within 8 weeks of the 4th dose. Next slide. And this shows you, Omicron shows particular excess of S1 mutations, and this is from next strain with Delta and the other strains. So Omicron is really a whole different subvariant. Next slide. And the rate of evolution, this is from Trevor Bedford, and this shows you that S1 involved at a rate of 12 amino acids mutations in per year in 2021. And this is, next slide, and this is the startling. And if you look at, again, from Trevor Bedford, who's a evolutionary biologist, the SARS-CoV-2, which we thought was a very stable virus and wasn't going to change that much, it actually exceeds H3N2, which is a very, which recombines, and we always think is a virus that's going to change a lot. But you can look at the rate of change here. It's significant. And so SARS-CoV-2 is evolving rapidly, and it's changing relatively fast compared to even seasonal flu. Next slide. And so what percentages have been infected since December 15th with Omicron? 9.8% of the US population has been infected, assuming a case detection rate of 1.1 to 5. About 50% of the US population has been infected, almost all within 10 weeks. So a remarkable spread within the US. Next slide. And then this is something heartening. This is 2 weeks ago, we looked at wastewater data, and this is, you can find this on the CDC website. And you can see 2 weeks ago, you had about 1,000% or more increase in all of these areas where you're seeing outbreaks between New York City, in these areas now where you're having increased rates of infection. Next slide. And this is as yesterday, all the rates have fallen now. So that tells you that we've had a significant protective rate, because even though we're having infection rates go up, our hospitalizations and our death rates have stayed flat. And that's because our natural immunity, along with vaccination rates, have really protected the elderly quite well in this country. Now that we finally kind of gotten enough vaccination and enough natural immunity through this. And this is, more blue is good. That means you're having a decrease in change, and red is bad. So, and this is a Cook County area up top near Lake Michigan, and you can see that we are actually improving. And so 2 to 3 weeks from now, we should be okay. And that's why you see all the public health officials being confident and not instituting a whole lot of measures. Next slide. And this is COVID today in Chicago. It's just pulled this off today. You can see the cases went up to 304, but the nice thing to look at is the deaths. We've had 0 deaths in Chicago. Hospitalizations are down. The testing, we're not doing as many tests as we were before, but still we're doing okay. The vaccination rate who have completed series, which means 2 doses, is 68%. And then what I've said it repeatedly, this is a 3-dose vaccine for the immunocompetent. Next slide. So what will happen? Next slide. Now, and you can see what's happening with Omicron. There's 2 scenarios. From you can have a flu-like drift, which is more likely going to happen with BA1 and BA2, versus a rapid emergence of a Omicron-like virus, in which case we're all in trouble, because then you're going to have another massive surge with another hospitalization surge and more deaths. Next slide. So more likely to happen, BA2 evolution to increase intrinsic transmission and escape Omicron-derived immunity, with waning immunity and decreased vaccine effectiveness and seasonality. So we need a new vaccine fundamentally. Less likely to occur is another Omicron-like event with a wildly divergent variant, which initiates another high attack rate event and another epidemic wave. Next slide. I think I'll stop there. And we're going to talk about treatment options a little later, I think. Should I talk about treatment options now, Ed, or let Kate? I think Kate should talk about Omicron, the variants. Ruby, can we have Kate start her slides? Because Ed? No, she's not. Can you let Ed unmute Ed?
Thank you. So we're going to go back to the order that we originally intended, and Dr. Kate Mullane, who is well known to us, will be offering a lot of information about what's happening from the viral genetics perspective and all the different changes that we're seeing and possibly anticipating. So Dr. Mullane, are you able to unmute? We're having the same technical issues.
She is unmuted.
So Dr. Mullane, are you able to hear us?
Looks like she can hear us, but we can't hear her. Okay, we can't hear what you're saying. It'd be good to just call in.
Can you want to have Dan go on?
Yeah, I think we're going to have to because we're going to run out of time. I apologize to everyone that we're running into this technical problem.
All right, well, happy to go. Thanks, Ed. So my name is Daniel Johnson. I sit on the COVID committee along with Doctors Chundy, Lynn, and Mullane. I'm at the University of Chicago, where I'm a pediatric infectious disease specialist, as many of you know. So I'll talk a bit about COVID as it relates to kids. And, you know, as you heard from Dr. Chundy, he did a great job of doing some comparison of Delta and Omicron. And of course, we have some data related to kids. And this was particularly interesting in that certainly the risk from Omicron appears to be greater in young children compared to Delta, which is a little bit unexpected given that Omicron for many has been more mild than Delta, but this is based on hospitalizations per 100,000 children, so it's normalized data, and it suggests then that Omicron is a bit more serious than Delta. Now, the explanation for this could very well lie in the fact that Omicron is less likely to infect lung tissue, but more likely to infect the bronchi. And given that young children have such small bronchi compared to the volume of the amount of air that they can move, they actually get more of a bronchiolitis-like picture or a croup-like picture, and that's what ends up landing them in the hospital. In fact, clinically speaking, that's what they present with. So you'll see that the incidence is about 14.5 per 100,000 hospitalizations for children under the age of 5. But we should hold on a minute and compare this to influenza. Next slide. And I circled the age group 0 to 4 there. And what you'll see is that the hospitalization rate for influenza in a normal year, so this is looking at 2019 through 2020. And in fact, maybe this is even low because, of course, you know, the tail end of the influenza season of 2020 is when we began to start doing mitigation against Omicron. So, of course, as you know, starting in March of 2020, so impacting them the 2020 US influenza season. But even so, you can see that the rate of hospitalization for young children from influenza is about 10 times higher than even the rate of hospitalization that was as a result of the Omicron. So again, even with that much higher rate that Omicron gave us for young children, it still was a mere pittance compared to what influenza does. Next slide. So, of course, this raises the question, is it really worth immunizing young children? I mean, right now we can't immunize them. There's no vaccine as of yet for kids below the age of 5. But if we look at the data for older age children, we're pretty reassured that it's still a good idea to vaccinate kids, be they between the age of 12 and 15 or down to age 5 or even below. And what this is showing is vaccine effectiveness. And you can see that in the blue is 2 doses under 150 days. In the orange is 2 doses greater than 150 days. And then we have a limited data set here for the gray for 3 doses. And of course, that's only in children who are a bit older because of our recommendations around who to boost and who not. But you can see that there is protection against ER and urgent care. Next slide. And you'll see that for Omicron, there's still significant protection for children. And so it does suggest that we want to be able to do immunization for certainly down to age 5. And then if we look at the next slide, you'll see that the protection by the vaccine against multisystem inflammatory syndrome in children is dramatic, with vaccine effectiveness in the 90% range, further suggesting that vaccination is important to protect children. So I think that we can say with reasonable assurance that there is value to vaccinating certainly the 5 to 18-year-olds, and likely there's going to be efficacy lower down once we figure out the right dose. Now, the other thing I just want to mention in passing is there were all these questions raised about whether or not the vaccine will cause MIS-C rather than protect against it. And we now have data, next slide, that shows that certainly the incidence of MIS-C is not increased in people who are vaccinated. And in fact, the number of children who get MIS-C who've been vaccinated is at most 1 per 3 million doses, or 3 million children who received 1 or more doses. And just to give you a comparison, MIS-C is the incidence from natural disease is about 1 in 3,300 individuals who've gotten SARS-CoV-2. Next slide. So, should we be vaccinating? Absolutely. Are you up to date with your vaccine? Well, for children and adults, I've included them on this slide, but really the emphasis is on the age group 12 to 18 for me, or maybe 12 to 25 because of adolescence. But you can see that if you're a normal host, you need 3 doses. You give a first dose, you then follow it with a second dose at 3. You can see here 8 weeks if you're using Pfizer, and for Moderna, 4 to 8 weeks. And that 8-week interval has been evaluated in the 12 to 39-year-olds, and I'm going to show you a slide on that in a minute. And for people 12 to 18, giving them a booster at 5 months is recommended. For the moderately or severely immunocompromised, well, then the recommendations are to get 5 doses. Second dose given 3 weeks after the first, or 4 weeks, depending on whether you're using Pfizer or Moderna. Third dose given at least 4 weeks after the second dose. Fourth dose given at least 3 months as a booster after a third dose. And then a fifth dose to be given at least 4 months after the fourth. Kind of hard to keep track. That's why I thought this was a very nice slide to share with you. Next slide. Now, I promised you to show you some of the data on the 8-week interval, and that's really about looking at the incidence of myocarditis. After all, we know there was some risk of myocarditis and pericarditis following the use of the immunization when given at 3 or 4 weeks with the mRNA vaccines. We got a very low incidence rate, around 50 per million doses, but nonetheless enough to make people anxious about whether or not to vaccinate kids in the 12 to 18 or 12 to 17-year-old age group. But if you see here that this is data out of Canada, where they looked at increasing the interval out to 8 weeks between doses. And what they found was that they dramatically reduced the risk of myocarditis, pericarditis, in fact, reducing it by about 2/3 to 3/4. And so at this point, many of us have recommended that for the 12 to 17-year-old age group, that you consider giving them their vaccine, not at the 3-week or the 4-week point after that first dose for the second dose, but rather stretching it out to 8 weeks. Next slide. And then there's reassurance because their antibody response by delaying is actually either higher or the same as having given it at the 3 or 4 week dose, suggesting then that perhaps the 8-week interval may very well be better immunologically. So should we be using this 8-week interval? Absolutely, especially when the incidence is low the way it is right now, because the trade-off by waiting is that you've increased the risk of not having had enough of an immune response after that first dose to protect someone. So what we're advocating here by waiting till 8 weeks is that it's probably worth the delay in order to lower the risk of myo or pericarditis, because the risk of getting SARS-CoV-2 has descended so much over the last month or so that there's less concern about the delay. Next slide. So just to finish off the thoughts about myocarditis and pericarditis, it's probably important to compare the risk of that, again, compared to individuals who don't get vaccinated, what the risk is from just natural infection. And you'll see that the risk from natural infection in the 12 to 17-year-old age group is about 5 times higher from natural infection compared to the vaccine if you use the more standard dose of 3 to 4 weeks, depending on the dosing regimen. And since the reduction is by a factor of about 3, you can see then that the risk is about 20 times higher if you extend that risk, you extend the vaccination out to 8 weeks. So there's just no doubt for the 12 to 17-year-old that we should be immunizing them. And you'll see that for the 5 to 11-year-old group, the case is even stronger because there's essentially no risk of myocarditis, pericarditis from the vaccine in that age group. Incredibly low risk, probably just baseline myocarditis, pericarditis. And therefore, we really don't have to worry about myocarditis or pericarditis for the vaccine for the 5 to 11-year-old age group. Next slide. Now, what's being up to date with the vaccine for 5 to 11-year-olds? Well, right now, there isn't approval yet or a recommendation for boosting this group, although I think there will be once the data is looked at a little bit. But to be up to date for a normal host is 2 doses, and for immunocompromised hosts, as you can see, is 3 doses. Next slide. Now, this slide is complicated, but what it's talking about is outpatient therapeutics. And for outpatient treatment of kids who get SARS-CoV-2, well, for the most part, there's little to worry about. But for children who are at high risk of progression, and I'll talk about who fits that criteria. For the child 12 and up, we do have options for outpatient treatment. And so first is that if kids get hospitalized, of course, we're not talking about outpatient treatment. And so here what you see is a rubric to follow that comes from ASPR. And what it shows is that if you're not hospitalized and your symptom onset is within the past 5 to 7 days, and as long as you don't have significant renal impairment or hepatic disease, then you could consider treating kids with Paxlovid. And again, as long as it's within 5 days, go ahead and consider giving them treatment. Now, this slide was generated at a time when you could also consider for outpatient management sotrovimab. But because BA2 is so, you could go ahead and hit the next slide. You'll see that I've taken off, nope, go back. Thank you. You can see that I've taken sotrovimab off and substituted bebtelovimab. And so you can use Beb instead because that has activity against BA2. And so you can consider that as an option both in the 12-year-old who weighs at least 40 kilo, who wouldn't be eligible for oral treatment, could then receive the Beb monoclonal. I don't recommend the use of molnupiravir and anybody below the age of 18. First, it's not approved in that age group, but also its efficacy is to be questioned. And so, again, the consideration for oral treatment is Paxlovid, as long as your kidney and liver are working okay, and consideration of a monoclonal, or if you can deliver remdesivir, then go ahead and consider using that over a 3-day regimen as is described here. Next slide. Now, one of the things that you'll want to think about is who's at risk for severe disease, because it's that group of children only that we're recommending currently that you consider treatment for. And you can see the list that's here. Probably don't need me to read it as much as to summarize it. And of course, it's children who have a high BMI, as you can see, greater than the 85th percentile, or kids who are undergoing significant immunosuppressive therapy, or who have diseases that lend them or make them highly immunosuppressed. And then kids who have neurodevelopmental or psychiatric disorder, or who have technology dependence, and I'm not talking about video games or computers there, I'm talking about technology as in tracheostomies or gastrostomies. The other kids to think about are listed there: sickle cell disease, those with functional heart disease, chronic lung disease where they require significant medical treatment, and you can see the rest. The only group that's a little bit controversy, and there's really not general agreement on, are kids below the age of 1 year with a history of prematurity. There is some data to suggest that they have an increased risk of harm, and so that could be a group that would receive remdesivir. They are not eligible because of their young age. As I mentioned, kids below the age of 12 are not eligible for Paxlovid, but could be considered for remdesivir. Kids below the age of 12 are also not eligible right now for monoclonal antibodies because we just don't have the data in that age group, although you would expect it to be helpful in that age group, but it's not approved as of yet. Next slide. So I just want to mention for monoclonal antibodies, It's a 1-hour infusion, which is part of the reason why it certainly can be done in an office practice, but of course you have to be able to manage anaphylaxis. And then really the only side effects are what you'd expect, which is a little inflammation at the delivery site. And rarely do we see any kind of systemic side effects. Next slide. For Paxlovid, remember it's 3 pills. One of the pills is ritonavir. And that means then that there's a whole host of drug interactions that we need to think about. Next slide. If you go back, thank you. And so, because of the ritonavir and its effect on the P450 system, you can see that there's many different drugs to think about: anticonvulsants, corticosteroids, oral contraceptives. And so it's really important to check to see what is going to interact with Paxlovid. Next slide. And thankfully, there are several online sources that you can go to. There's the Liverpool COVID drug interaction. There's the NIH treatment guidelines. And then there's just the EUA that you can download. I'm sorry that for some reason there's coverage of those websites, but you can just Google them in order to locate them. Next slide. Now, for kids who are under the age of 12, the only outpatient available treatment is the use of remdesivir, as I've already mentioned, and you can use it down to kids who are 3.5 kilo in size. And so that's a way in which you can go ahead and treat those who are at significant risk for progression to severe disease. Next slide. And again, it's the same group of patients. I won't repeat it. Next slide. So the last thing I just want to touch on, because we did get a question about masking in school. And do we recommend that people continue to mask in school? And the simple truth is you should let people do what they want to do in this time, because the incidence of disease is so low at this point. If it was my kid going to school, I'd tell them to wear a mask, because why have them have exposure if they don't need to? But if they weren't comfortable doing it, I would just tell them not to worry, because the risk is so low right now. But we are seeing some outbreaks in school. And so we know that the trade-off for giving people this flexibility is some risk of acquiring SARS-CoV-2. Now, for the young child, as I showed you at the outset of my comments, the risk to them is very low. But they can bring SARS-CoV-2 home. And so if my patients ask me what they should do, I tell them, try and have your child wear a mask, but make sure that everybody in the household is immunized. So that way, if that child does bring SARS-CoV-2 home, that the risk to the members of the household is as low as it can be. Next slide. The next slide now goes to Kate, hopefully, who has solved her technology problems. Kate?
I think I'm good.
Oh, there
Can you
you
hear me?
are. Wonderful.
Yay.
Yes. Bravo.
So we have a multimedia event here. I'll just kind of repeat from our last chat. Where did Omicron come from? Some people think it's been present all along, although because it's so highly transmissible, that's sort of in doubt. It may have emerged over a longer period of time in immunosuppressed people, and that's, I think, where most people are believing that this virus accumulated. And we have some data on HIV patients and on immunocompromised transplant patients that were able to grow this virus or variants of it over a long period of time. There's some thought that it leapt back and forth between animals and humans, and we know that that can happen with SARS viruses. And then lastly, recombination. We know certainly the BA.3 is a recombinant variant of the Omicron species, and so that may as well have some play in how it's come forward. Next slide, please. So this is a lineage. There's multiple variants of the Omicron species. So just like alpha, beta, gamma, and delta variants differ from one another, so do the BA variants. And the three primary ones that we know now, although there could be many more, are the BA.1, BA.2, and BA.3. BA.1 was our first that we identified, and this was surprising because it had so many different mutations compared to what the other mutant viruses had or the other variants in the past. So there's probably over 50 mutations that are different than the original Wuhan strain, and 32 of those are on the spike protein. And that's compared with 10 for the alpha virus, 12 in gamma, and 9 in delta. The first of this infection was noted back in November, but as we'll see on one of the variant guidances, it probably was initially identified back in March of 2021. The BA.2 has 27 additional mutations from that seen in BA.1. It differs from BA.1 in 28 mutations. It doesn't have the major S protein mutation S69 to 70, which is very important in transmission. It was first identified in India and then as well in South Africa at the end of December. And I highlight the in yellow those mutations which are the most important that are present for infectivity and for aggressiveness of the virus. BA.13 has 13 additional mutations, and it seems to be a combination of both BA.1 and 2. It's lost 6 of the mutations from BA.1, but obtained 2 from BA.2. And it was discovered in northwestern South Africa, which is different. Most of the other variants that we see in South Africa come from central South Africa. Next slide, please. So the big difference with the Omicron variants is if you look at the top in the purple and pink, darker pink, that is the receptor binding domain. And most of the virus mutations that we've seen previously were in that receptor binding domain. However, with the Omicron species, we're seeing many of the mutations occurring in the spike domain. And that's important because initially after the virus attaches at the receptor binding domain, it folds on itself. And that stalk is what allows the virus to pretty much articulate with our cell wall and inject the virus's RNA into our cells. Next slide. So as you can see, Omicron is pretty much a different virus from the earlier viruses that we've seen. It's got its own lineage. The 21M Omicron is kind of the beginning lineage of the Omicron family, with the 21K being B1, 21L being B2, and that little red dot is the start of the BA.3. So we haven't seen much of it. It doesn't appear that at this point in time it's very aggressive, but we'll have to see what happens with time. So as I said, the Omicron parent, or the 21M, we believe arose around March of 2021. And then we have this Omicron family with the firstborn child being noted in November of 2021. Next slide, please. And as Dr. Chundy noted before, the importance that we see with Omicron compared to some of the other variants is how rapidly we see its uptake. So you can see with Delta in the kind of teal color, its uptake was progressive and slow. It wasn't a sharp, huge uptake as we see with Omicron. And the beta 1, the beta 2 seems to be a little slower in its uptake compared to the original B1 variant. Next slide. So what makes it different? Well, the major issues with Omicron is the high transmission rate. The BA1 had about a 3 to 4-fold more higher transmission rate than Delta. And with BA2, it looks like it's a 30-fold increase in its transmissibility. The mutations increase the affinity for the attachment to the ACE2 receptor site. And as well, it uses not only the ACE2 receptor site to infect our cells, and we'll look at that. It has an ability to evade our antibodies, especially the neutralizing antibodies. And as we talked about last time, the spike doesn't show its receptor binding domain until just before it's going to infect our cells. And that allows the virus to evade our immune system, and probably why it takes a while for us to see an immune response after we get infected with it. It has a very high replication rate compared to Delta. It's about 70-fold faster replication in our bronchi in the first 24 hours. And we see a very high viral burden, and that's what allows it to spread. Deeper in the lungs, we see the other variants where Omicron tends to replicate more in the upper airways and in the bronchi, and that's as well why it's much more infectious, because we see many more viral particles there. But because it's not deeper in the lungs, is that why it's less severe? Maybe. And we know with all of these viruses, it's impossible to tell where it's going to go in the future. Next slide, please. So the key concerns with the new stealth virus, or the BA2, is that it can reinfect those people who've had other variants, but as well, we have seen people who have had BA1 get infected with BA2. Not as commonly, but the immunity and immune protection is not complete. The vaccines are less effective against BA2 than they were against BA1, and certainly less effective than against the original and the alpha strains, which you've seen a little bit of, and we'll look again. Protection with all of our vaccines appears to decline over time, and it's primarily we don't have high antibody titers that are circulating. And so we're dependent on reactivation of our memory cells to develop antibodies and show activity. And so we see then when people get a booster that their protection is restored. However, as has been already noted, hospitalizations and death rates are markedly decreased, and we'll show you some data on that. But it's just a reminder that this virus continues to cause harm, particularly in those people who are unvaccinated or under-vaccinated, and in those who are vulnerable populations. In Hong Kong, the surge in BA2 showed us that. The elderly in Hong Kong had a lot of vaccine hesitancy, a very low rate of vaccination, and that's who was primarily infected with this virus. The global uptick happened while countries had lifted a lot of their public health interventions. And so that as well may be a reason why we saw the surges in Europe. Next slide. So when we look in the United States, the case reports have kind of been stable. But when we look at hospitalizations over on the right of your slide, they have fallen off even though the rates of infection are high. So again, that tells us that while the rates are high, hospitalizations and as well in the lower right-hand side, deaths have fallen off. So that's a good thing. Is it because of vaccination? Is it because people have been infected and we're seeing endemicity of this either virus or protection from the vaccine? Probably that is so. Next slide. So again, what makes this different? The cellular entry is different. When we look at the binding of the virus, it not only has binding to the membrane, which is how the initial SARS virus infected us, and the TMP RSS2 pathway was how it attached by the stalk and then released its RNA into our cells. But now we see it goes into an endosome. And so again, from some of our intracellular activity of attacking the virus or protecting us, that's lost. Next slide, please. So the vaccines, however, our activity isn't zero. And again, there's a little crossover on this, but our booster doses in those who are fully immunized have shown marked decrease in the likelihood of people getting infected. So in kids, we don't see as many vaccinated yet, but in our adult population, especially over 18, you can see that most of the hospitalizations are occurring still in people who are unvaccinated. And in those patients who are either fully vaccinated or at least have gotten 2 doses of vaccine, the likelihood of hospitalization is low. And as well, in the lower right-hand corner, the likelihood of death is low. So when we're looking at hospitalization, the unvaccinated patients have a 6-fold higher rate of hospitalization if you're over 65, a 5-fold higher if you're 50 to 65, 4-fold higher if you're 18 to 49, and then falls off less in the group that are kind of catching up with our vaccinations now. And the same is true with death rates. And it's across the board with all of the vaccines, Moderna, Pfizer, and Johnson & Johnson. Next slide. So what are we seeing here in the US? Yes, BA2 has overtaken BA1 to become our predominant virus that's circulating in the United States. And as you can see, Delta isn't even on the board anymore. It's gone. Next slide. And with that change, we have seen a decrease in our effectiveness of vaccinations. But if you remember all the way back to the beginning, when we looked at where did we want vaccine efficacy, or where had we hoped that we'd see vaccine efficacy, and it was in the range of 50 to 60%. 65% was our goal, our aspiration, and we're still seeing in the range of 50 to 60%. And so we're doing okay with the vaccines. What does that mean with the vaccine manufacturers? Well, they have had variant vaccines already that they've looked at in studies, and thus far have not shown any better protection than the initial vaccines. So we do have those coming forward, but we don't know when the trigger is going to be pulled for industry to use those, because at this point in time, there's no push to do that. Next slide. So as you've already heard, sotrovimab is now taken off the market. It's no longer available. If you remember with the Regeneron product, even though it was pulled off and there was no activity, there were 300,000 doses that were given because governors demanded that they have it. I don't think that that's going to happen with sotrovimab unless we see a change in what variants are out there. The agents that are expected to have activity, you've already heard Paxlovid, Veklury, the remdesivir, molnupiravir, and Lilly has had a resurgence of having an active antibody in bebtelovimab. Next slide, please. There is no data that I can find. It's been used subcutaneously in animals, but it hasn't been the Lilly monoclonal. It hasn't been approved as a subcutaneous injection in humans yet, which is the nice thing that we had with sotrovimab and with with Evusheld, that both of them can be given subcutaneously. So we'll have to see for ease of administration in the future. So we look at neutralization of Omicron BA1 and BA2 with the Pfizer vaccine. From studies that looked at the prime and before the booster, our levels against the BA1 and BA2 were quite low. However, once people got boosted, antibody levels rose quite high. Next slide. And we see the same with Moderna and with Johnson & Johnson. The initial antibody titers before getting a boost were low, but once people got boosted, they rose. However, as Dr. Chundy said, after 8 to 12 weeks, those antibody titers fall. Next slide. And so when we look at long-term after getting boosters, we start seeing the curves blending and the immunogenicity falling. And a good question is going to be, how often are we going to have to get vaccines to keep those titers up? And I'm just saying, a guy in Germany has gotten over 90 doses of vaccine because he was selling vaccine cards, but he didn't have any toxicities that were associated with it. And I don't know that he's had any benefit with that. So I think, again, time is going to tell. How often do we have to get revaccinated? Is it going to end up being a once-a-year vaccine? And are we going to have different variant vaccines represented in the vaccine products as we go forward? Next slide. I guess that's it.
So thank you very much, Dr. Mullane. Always impressive. I want to urge everyone to hang on a little bit. We're going to go over the hour because we started late and we had some delays, and we have a list of questions that we've been fielding and want to share with you, okay? So the first question, are the current vaccines effective against Omicron to prevent infection and increase hospitalization and death? And I think that has been fairly well covered in tonight's lecture. I don't know if any of our panelists want to add anything, but the answer is it's a definite yes when you look at people who are up to date with their vaccination, or that they have the hybrid immunity from natural infection and vaccination. Any other additional comments you want to make? I'm turning to the panelists.
I guess the only comment I would make is as the variants happen with the viruses, in our bodies, we have somatic hypermutations, and we ourselves, for our antibodies, make variant antibodies. And there's some thought that maybe that's why we still see activity of these vaccines against the Omicron species. Again, how long is that going to last? We don't know.
Thank you. The next question, what is the optimal dose of vaccine for ages 5 to 30? Dan, you want to work your way up there?
Sure, no problem. I think I mentioned in my slides the dosing regimen, but I'll take this question as optimal dose, and that's why I'll emphasize the word. So first is that in terms of dosing regimen, I think with the incidence of disease being low, the optimal dosing period is right now looks like 8 weeks. It's in some ways not surprising, given that there are several vaccines that have been created for children where 8 weeks between first dose and second dose seems to be relatively ideal. As to the amount of antigen, well, we don't really know. I mean, these were guesses. We don't know the optimal amount of antigen for adults. We don't know the optimal amount of antigen for children. What we do know is that the reduced dose the children between the ages of 5 and 12 receive lowers the risk of side effects. In fact, if you compare the side effect profile of the placebo agent compared to the actual dose that was given with Pfizer, they were equivalent in terms of the side effect profile, with the exception of a sore arm. where the placebo really didn't cause much of a sore arm in comparison to the actual dose of the vaccine. But there was a trade-off, which is that we have seen vaccine waning likely faster compared to a higher dose that might have boosted the amount of antibody to higher levels. So the answer to the question is nobody really knows the optimal amount of antigen to be given or the amount of mRNA to be given. But we do have at least some data on interval dosing, and that interval data suggests that 8 weeks is probably better for people than is the 3 or 4 weeks.
Thank you. So question 3 is one that we're getting with a great deal of regularity now because it's received a lot of coverage in the popular media. And that's the issue of mixing and matching or mixing the mRNA vaccines. Just as an aside, will say that in terms of booster dose, additional doses for the J&J vaccine, it's being strongly recommended that you only use the mRNA vaccine in those situations, unless there's an unusual problem with, let's say, an allergic reaction to the mRNA platform. I'm going to throw this open to my colleagues because I think we've discussed this before, and I think we should share our thoughts.
Yeah, there's lots of good data now that shows that mixing the vaccines, not just the mRNA vaccines, but out of Britain, the adenoviral vaccines with the mRNA vaccine has some advantages. And, personally, if I had 2 or 3 doses of the Pfizer vaccine, I would take the Moderna vaccine, which is exactly what I did, because it just makes you get a better immune response. That has not been yet, it's not something that we could go out and say, it's been trialed and done, but clearly the adenoviral vaccine with the mRNA vaccine has been published in Britain and shows good efficacy.
We talked about the decrease in the multi-system inflammatory disorders amongst children, but will the vaccination decrease the long COVID syndrome we're seeing?
Kate, you want to take that? I mean, it should. This is the whole hope of treating or vaccinating people and then treating people now with Paxlovid and monoclonals, because even though you may not have a whole lot of symptoms, you certainly have a higher risk of getting long COVID. And that's why vaccination is so key to all of this. Long COVID is a real thing. It manifests with neurological issues. If you go to ENT people, they go, oh yeah, one loss of hearing in one ear, Omicron. I mean, they'll say COVID. If you go to dermatologists, urticarial rash, they'll say COVID. So it's causing all sorts of issues, GI and neurological, ENT, smell. So certainly, I think early therapy will decrease long COVID. Vaccination will decrease long COVID. And once the cat's out of the bag, the cat's out of the bag if you don't catch them early.
The projection the federal government has for managing long COVID is $17 billion. So I think it's something that is really important and why vaccination should be used. When we're looking at the incidence of COVID in people who are vaccinated being much lower than those people who are unvaccinated, we know that long COVID is higher, although not zero, but higher in people who end up in the hospital. Yes, vaccinations are important, and that's where our tax dollars are well spent.
Thank you. The next question regarding Paxlovid and Molnupiravir working against Omicron. We've touched on this a little bit, I think, in a couple of the different speakers. Does anyone have any additional comments you want to make about it?
Well,
yeah, go ahead.
It works.
Yeah.
Paxlovid is probably better. Molnupiravir has a lower efficacy rate. In the test tube, it has a better activity, but in human beings, it seems to only have about a 30% improvement overall. So I think most people would say if you can get Paxlovid or you don't have drug interactions that you have to be concerned about, that's probably going to be the treatment of choice. And if someone is pregnant, you don't want them to get molnupiravir. And if you don't have any other drugs or you have drug interactions, then molnupiravir is the choice.
Thanks. Kate, I'm going to toss you question number 7. Why are people getting reinfected? I know you covered it and it's been mentioned. I don't know if you have any other additional comments you want to make about this.
Well, yeah, because I think the mutations, our initial vaccines were geared, the mRNA vaccines were geared against the receptor binding domain, not against the entire spike protein. And so because we're seeing mutations along the stalk, and we're seeing infections with those. As well, the mutations that we see from the Omicron changes the way the receptor binding domain expresses itself, and it's folded on itself. So as we talked about a little bit, until the virus sees a cell that it's going to infect, that receptor binding domain is inside the cell. Well, now that we have these mutations, it's as well blocked. And so our antibodies that are geared towards that area of the virus are not able to work. That's why we need high titers. It's stoichiometry, as we talked about it in the past. The higher the number of antibodies that you have present, the higher the likelihood that you're going to be able to prevent it. And yeah, so that's why.
So the next toss up, who would you recommend getting Evusheld? And does it work against Omicron?
Well, it depends on how available Evusheld is. So when you look at a lot of the university centers, they're running low on Evusheld, yet a lot of the Evusheld is just sitting on the shelves. So clearly the highest risk groups, acute leukemics, people with oncological issues, people receiving significant B-cell suppression should get Evusheld. And the vaccination in Evusheld. And people who have the second, it's tiered out actually quite clearly. People receiving B-cell suppressive therapy for lupus and other conditions should also receive Evusheld. And then and then people with less immunosuppressive therapy on the third tier. And so, based on availability, these folks should get Evusheld. And the recent studies show that it's very efficacious against Omicron, up to 90% efficacious, even when given half the dose as in renal transplant patients that were just published out of France. So clearly, Evusheld is indicated. It's just the availability. I mean, any other comments, Kate or Dan?
Yeah, the only other comment I would say is, it's important to look at how immunosuppressed people are. And we've had patients that have had 4 doses of vaccine and have absolutely no titers of antibodies. And if you're in a pinch and you don't have a lot of Evusheld and you're trying to say who should get it and who should not, I think that is the probably only time that I would recommend doing antibody titers. And if the titer is less than 1,500, then they should get Evusheld if you can. If it's higher than that, then they're probably okay. And that's where we get into the millions of different MIDs, IDs, and MABs that are out there being used for everything from psoriasis to ulcerative colitis and other disorders. And, when we're looking at who should get it and who should not, that would be kind of an acid test.
So the next question was, how good are rapid tests to detect infection? And I'll start off by saying they're very good at detecting infection. It just depends on the amount of virus that the individual is producing at that moment. So sometimes you have to pair the tests over a period of time in order to catch it. Certainly in symptomatic people, the rapid test has an excellent correlation. So in general, these tests, when used correctly, can be very, very useful. Any other comments for anyone else about this?
Yeah.
So
Sure.
Omicron isn't so good with the test. And that's one of the reasons that BA1 was missed, and BA2 is even less likely to be captured with the over-the-counter test. So I think a negative test should not, if you have symptoms and you have a negative test, you should not feel confident that you don't have a disease. If you have a positive test, then it's great, you know that you have it. But I think that false negative test rate is of concern. So I think symptoms and testing are both important.
Thank you. That's very important. When can I tell my patient it's safe to be around others after being infected with Omicron? This is a very common question.
I'll take this from an infection control perspective. This whole thing at 5 days was, you can go ahead and come back to work and do this in 5 days, was at a time when we had no workers in the hospital because of the huge surge in January. But we do know that people frequently shed virus up to 8 to 12 days. So you should be asymptomatic, number one. That means no symptoms. And then preferably if you have a rapid test and you do a rapid test and your test negative, you're safe to come back. Otherwise, you should wait a full 10 days. Earlier than that, you put, especially if you have people who are older or have immunocompromising states, at risk for catching illness.
It really does depend on who you're worried about exposing. And we do know that if the infected person wears an N95 or a KN95 that is reasonably well fitting, that provides a great deal of protection to others that are around them. And so if someone is out at the 5 days, it is reasonable, as long as they're wearing a well-fitted mask and they're not going to be around immunocompromised hosts, to feel that if they put on that N95 or KN95, they don't have to isolate to the same extent. Now, if you're immunized, most people stop shedding at around 8 days after symptomatic disease. So that's the other thing that you can reasonably well rely on. So it does provide some variability. And I think that's why it's so hard to answer this question, because it does depend on who you are, what your vaccine status is, and who you're going to be around.
I know in the chat that there's been a number of questions about masking, but this is also a strategy that if you're asymptomatic and your test is negative, but it's been a short duration, you haven't gone the full 10 days, most people would recommend masking, especially if you're going in a situation where you're worrying about transmission. The question about vaccinating unvaccinated patients once they've been recently infected. I know that the old recommendation when vaccines were first being used is no longer the case. And we also know that these people will have some immunity, but how does our panel feel about when to vaccinate these individuals?
I use the HIV thing where, the best time to start, the best time to get them vaccinated is right away, because that's when you have a receptive audience. And so I tell my folks, just come in and get vaccinated. They're worried about, they're still applying that 90-day rule that we had before. That doesn't apply anymore. So I bring them in and just get them vaccinated as soon as possible, usually within 2 weeks after infection, 4 weeks at the latest.
Yeah, in the environment that I work in, that's been our position, as long as they're asymptomatic and afebrile.
Yes. Asymptomatic and afebrile, correct.
Yeah, I mean, we're more worried about the people who are doing the vaccination, not getting exposed needlessly. So we want the person who's gotten recently infected to be ideally out the 10 days.
2 weeks.
That would mean that they don't present much risk to anybody that's around them.
Okay, question 12. How long does protection persist with, following the fourth dose. And I know that the data that Dr. Chundi presented and mentioned the Israeli study that received a lot of publicity this week in the New England Journal of Medicine. They admitted that their study only went out 6 weeks. And we have other studies that have suggested it. But I think the important thing here is it depends on how you define how well does protection last. So there's protection against infection or acquiring enough of a disease that you trigger a test versus protection against hospitalization and even death, severe disease. And that's where I think the data look really good from the study that was presented from Qatar. Vishnu, do you have any additional comments about this or anyone else?
It's really, like we talked about, this is a 3-dose vaccine for the immunocompetent, 4-dose vaccine for the immunocompromised, and the booster is the next dose after that. Protection against infection lasts for about 8 weeks. Protection against hospitalization and death lasts much longer. And so, what I would do now, I think when the incidence of disease is low in the community, is wait. When people ask me, well, should I get a 4th dose? I said, the incidence is very low. Your protection against infection is short time, 8 weeks. So I think if I look at my little crystal ball, which has been wrong a lot, I would say, we're going to have we're going to have problems in fall when our immunity wanes and we have people up and about. And so I would wait until the rates start going up. And you saw from our if you look at the data on the website from CDC with the sewage data, what's going to happen in the next 4 weeks. Your rates are going to go down. And I think what you're going to see is immunity wane, and then you're going to see rates go back up later in the year. And so based on the community prevalence, I would wait right now, unless you're immunocompromised. If you're immunocompromised or you're over 65, and you have diabetes, other comorbidities, go ahead and get the 4th dose. Dan, you're the vaccine, guru.
Yeah, no, it's really that latter part that I think is the answer I provide, which is that if you have a risk factor that puts you at risk for severe disease, then you should definitely get that 4th dose if you're above the age of 50. If your health is good and you're between the ages of 50 and 65, then I don't think it matters whether you get the 4th dose at this point. But if you're above the age of 65, the data out of Israel shows that you pick up some protection. And trying to predict when the virus is going to change, when we're going to see a new version of the virus, that crystal ball, I don't think anybody has it. I mean, that's the lesson that we learned from Omicron, was that Omicron came out of nowhere and it just ran right over us. So I would say that if you're eligible to get that 4th dose, go ahead and do it. You'll probably be getting another dose in the fall, but who cares? It doesn't look like getting more doses is going to be a problem. It's only getting less doses that puts you at risk.
Okay. Is it safe to travel, guys?
Well, I'm traveling, so I'd say the answer is yes.
It probably depends.
I'd say yes and no, because when people travel, suddenly all their inhibitions are gone. People who didn't know how to ride motorcycles, people who don't belly up to bars, go up to bars, and strike up conversations with everybody. And that's the issue, is the inhibitions go away when you travel to outside areas. So, a lot of people are getting infected when they travel because they don't follow the same precautions they were following at home. But if you wear a mask at crowded indoor situations, it's certainly safe to travel. I mean, I'm planning on traveling, but I'm also going to carry my N95 mask with me because I know you're going to be in circumstances when you're going to get yourself into trouble, especially in airport lounges and in the Ubers and other modes of transportation when you're stuck in a close quarter with someone you don't know their vaccination status and their risk behavior. So I'll stop there.
No, I think that's accurate thing. And also, I think it's also useful to understand where you're going. So if you're doing international travel, obviously there are some areas you want to be more concerned with. In the United States right now, things look pretty good in most places. And, the CDC and again, I'll go back and I'll reinforce what Dr. Chundy said. The New York Times has some wonderful data that is, easy to follow. That may help guide you a little bit.
I mean, the critical thing is to use good judgment, right? There's just no reason not to wear a mask, especially given the efficacy of mask wearing, which is significant. So, why not wear a mask in any setting where you can? Why expose yourself to risk that isn't necessary? Everything's about incremental risk and what you're willing to do. And we know that if you wear a KN95, you wear an N95, you wear a surgical mask that fits well to your face, that it provides significant protection on the order of anywhere between 80 and 90% or more in terms of reduction of particles making it to your nose and mouth. I'm traveling, but I'm also wearing a mask on the airplane. I'm wearing a mask in the airport.
Now we're looking at children and masking. Dan, you already covered that during your talk. Anything else you want to add?
No, I just want to reiterate. I think that the risk of disease to children and the complications of it are sufficiently rare that we're talking about either a better case scenario or equivalency to influenza. So what did you do with your kids with influenza? What did you recommend to your patients around influenza? And I'd say that should be your guide. If there's somebody at home who's high risk, then of course your threshold for having your child wear a mask is going to be lower than if everybody's vaccinated in the house and you have good reason to believe that they responded to the vaccine. Well, then your need to have your child wear a mask in school is much less. There's some risk to them. There is some risk of MIS-C, but it's pretty low. And in terms of long COVID, it's not even clear yet that there is a real risk of long COVID in children. And for children and long COVID, the incidence looks like it's somewhere in the range of 0.5% to 1%, and the best data that we have so far. And in almost all of those kids, 90% of them show evidence of full recovery by 6 months. So again, the risk equation for children is just dramatically different than the risk equation for adults.
You touched on the issue of influenza, and that was the next question. When you compare it to COVID in children, how pathogenic is influenza?
Influenza for kids certainly below the age of 5 is 10 times the risk that COVID is. So really the goal should be to get our kids vaccinated against influenza, not because it's great at protecting them from getting influenza, but it is great at reducing their risk of hospitalization or death from influenza. As you get older, of course, the risk of COVID rises, but even up to age 18, the risk from influenza appears to be less than the risk, the risk of influenza appears to be greater than the risk of COVID.
So the question about the official recommendations for vaccination of pregnant women, it's a very simple answer. Absolutely, all pregnant women should be vaccinated. All women who are lactating should be vaccinated, and all reproductive age women who are even contemplating pregnancy should be vaccinated. And these recommendations come from the American College of OBGYN, the Society for Maternal Fetal Medicine, and the CDC. It's all good news when we're looking at vaccination and pregnancy now, and we have abundant data. You know, we can no longer hide behind the fact that pregnant women weren't knowingly admitted in the original clinical trials for the vaccines, but we do know now that there's been, tens of thousands of women who've been followed, who've been vaccinated. Clearly, COVID is not a trivial problem in pregnancy, and it's actually one of the risk factors for more severe diseases being pregnant. And so the benefit for vaccination, and I'm recommending the basic, two vaccine series plus the requisite booster additional doses, for pregnant women should be done. And, as I say, I think we've shown it to be efficacious. We've shown it to be safe. We know there's passive immunity that's transferred to the fetus, and early indications are that the same thing is occurring in neonates when mothers are lactating who've been vaccinated, who are able to transfer antibodies, including IgA. And so it's all good, yet we only have about 60+% women in the United States who have been vaccinated in pregnancy, and they are considered part of the high-risk group. So the last question that was put out is it safe to go to bars and restaurants? And I'm assuming now we're talking about in terms of COVID and not the northern suburbs where there's been kind of a minor epidemic of norovirus enteric infection going on right now.
I would say depends on the bar and the restaurant. Restaurants with high ceilings and good spacing and good air turnover, you're pretty safe with low incidence in the community. Crowded bars with low ceilings, everyone's sitting next to each other, and high incidence in the local area, you've got problems. Now, if you're sitting in Hawaii and you've got the ocean breeze blowing through the bar, and you're pretty safe. But sitting in the local bar in Chicago, is going to be an issue if you've got community transmission, and you've got some community transmission based on our Chicago data there. And so, I would recommend if you've got a good air turnover in the bar and it's an open bar, you've got stuff blowing through, you're pretty good. But you've got to take that circumstance and assess it carefully when you go to these places at the risk. I simply walk out if it looks like it's a dangerous place.
Yeah, I've been looking for geriatric bars in my area because there's such a high vaccination rate amongst that age population. That you feel much more comfortable. But that's the whole issue. It's where you are, and we do know there's areas in Chicago with low vaccination rates, and whether that's translated to restaurants and bars in that area, it's hard to determine. But I think dining in a restaurant is a little different than necessarily being shoulder to shoulder in a bar, and especially if the people in your immediate vicinity, what their health and vaccination status is. It's a little bit more reassuring. But again, pay attention to the environment and see how comfortable you are.
Try and stay out of bars during sporting events. All the cheering and hollering certainly puts out a greater risk of viral exposure.
So people in North Carolina and in Kansas are going to be at high risk.
Yeah.
Well, I want to thank all of the panelists for really yeoman effort in dealing with some of our technical challenges. I don't know when we're going to hold our next one of our town halls, but the Medical Society, I want to thank them for helping us get this information out. Unfortunately, it looks like this issue is going to be with us for a while, so I'm expecting that we'll be asking you to tune in again in the not too distant future. And I wish you all well, and stay safe and healthy.
All right.
Thank you.
Good night. Thank you.